Okay, so just very quickly, I'm Rebecca Eaves. I'm the manager of the Safeguarding Adult Board and Children's Partnership in Coventry. For those of you who aren't aware, the Coventry Safeguarding Adult Board, the Adult Board is a statutory requirement laid down in the Care Act. We are required to set up a formal body made up of statutory and voluntary members, and our role is to oversee how adults are safeguarded in the city. We've had an independent chair who opened the event today, Derek Benson, and you can see listed there some of the members of the Safeguarding Adult Board. Next slide, please. Okay, so what we do, we give leadership and guidance to agencies. And for those of you who haven't seen them, please go onto the website. We develop adult safeguarding policies together with the other West Midlands regions. So we've got regional and local policies on that site. We also check that arrangements are in place to deal effectively with allegations of abuse and neglect. And we aim to enable the professionals who work with adults with care and support needs to act to keep people safe, while ensuring that those accused of abuse or neglect are dealt with appropriately. We also undertake safeguarding adult reviews or learning reviews, and the focus of those reviews, it's not to apportion blame, it's to make sure that we understand where the system needs to learn and that we make sure that those improvements are made. The next slide, please. Thank you. To find out more about the work of the Coventry Safeguarding Adult Board, please go on our website. Tom's popped the link in the chat earlier on. Tom, if I could just ask you to do that again, please, so people have got it to hand. If you scroll down on the link, there is a box where you can sign up for our newsletter. So if you haven't yet, please sign up for that. And as I said, we send out updates and it will include the recording of today's session for those of you who want to access that. We also produce an annual report that's also on the website. So please go on the site and have a look at that. I can see I've got a hand up. Did somebody want to come in? I can't see who it is. No, maybe not. Okay, so I'm now going to hand over to Liz Kiernan. Liz is the lead nurse for safeguarding adults at UHCW, and she's going to talk to you about a case study involving making safeguarding personal.
Thanks very much, Rebecca. Let me know if I'm not talking loud enough, but I'll carry on like this unless I hear differently.
We can hear you, Liz.
Thank you. I'm Liz Kiernan, named nurse for adult safeguarding at University Hospitals Coventry in Warwickshire. And the case I'm presenting today is a very health-based case. However, it has all the aspects that was pointed out so well by Professor Preston Shute earlier, and some of the speakers that we've had who've had their comments. So first slide, please, Lillian. Okay, so this is about a couple really. Our patient was Tom, but he was in a couple with Jenny and they'd been married for 50 years. So very much they were one entity really. Everything was about each other with them. They were totally entwined and they really, really did know each other very well. They enjoyed their time together. They made most of their time together. They loved meals. They loved meals at home. They loved meals going out when they were more able. And they loved family parties. Everything to them was about food. And it made me think when we had a comment about the dog food from, I think it was from Shazia, that actually food is so evocative. And the gentleman she was talking about, he was so concerned about his dog having his food. So this is a very food-based case, and it's about a couple who very much knew each other and wanted the best for each other. Next slide, please, Lillian. So we looked at Tom really. We're a health organisation. We look at health problems. We try and fix things. We try and get things better for people. Care of people, as somebody commented, is centre of everything we do, and we really try to get it right for people. And for Tom, he had some brain damage. He'd got small vessel disease in his brain, which is the start of dementia in a way. It's the multi-infarcts in the vessels in the brain, or little occlusions in the vessels in the brain, which obviously causes poor blood flow, oxygen deprivation to the brain, and can lead to problems such as thinking problems and reasoning problems, but also it can come out physically. And with Tom, he was unfortunately becoming less mobile. His body wasn't always doing what he wanted it to do. His brain wasn't able to give those signals to his body, so he was having the mobility problems, and sadly he was also having swallowing problems. Swallowing problems, we all know, I think we all know, although as Professor Preston Shute said, we have to put ourselves in the person's shoes, and we can glibly say swallowing problems, but when we stop and think about it, how huge are those problems for the individual? Not able to eat the food that you enjoy, perhaps have to eat a modified diet, or even maybe stop eating. Tom was experiencing coughing when he ate, which can be frightening. The feeling of choking, the feeling of suffocation, very, very scary. And because some of that food and drink was going down the wrong way, he was getting chest infections. And we know that chest infections from aspirating on food are a leading cause of ill health amongst the older population. And because of this, he was experiencing weight loss. He was unhappy, his wife was unhappy, and he was experiencing loss of weight, which overall was not good for him. Next slide, please, Lillian. He was seen by his GP, and some planning was done that was really, really inclusive of Tom. They did a scan of his brain, and they confirmed that there was some vascular brain damage, and that probably was the reason he was experiencing difficulty with his swallowing. So they discussed it. What could we do? This is a problem, we need a solution. So he was referred into the hospital to have an endoscopy, a percutaneous endoscopic gastroscopy, which is the insertion of a tube into the stomach via the outside, using a little camera that goes down inside the person's gullet, really, to visualize where it goes. So that happened. It's a solution. The gentleman was having trouble eating and drinking, and that was the solution that happened. Next slide, please, Lillian. So he came into hospital. He was admitted for the insertion of the PEG, which is the percutaneous endoscopic gastroscopy, and he was put nil by mouth. Now, anybody who's been nil by mouth for any length of time for a surgical procedure will know how debilitating it can be, how you can feel thirsty, how your tummy can rumble, and that's just for a few hours. He was told he was nil by mouth. So he was also told that the procedure went really well, and he could get back home, get back to a normality, not the normal that was normal for Tom, however. His wife agreed to manage the feed, but what came out at the meeting we had was she agreed to manage the feed after she'd been asked 3 times by 3 different professionals, all well-intentioned, all trying to do the right thing for Tom. He wanted to get home, he wanted to get back, he wanted to be with his wife. However, taking on the management of a feed is a big ask, and something that nurses have extra training for, let alone doing it at home when you've got no senior support around you. So he was discharged home. He had been in hospital longer than he'd been told he would be. Because we were trying to get things right, nobody was trying to hold up his discharge. We were just trying to get things right for Tom. But actually, it made Tom unhappy because he stayed in the hospital quite a while, quite a number of days, longer than the 48 hours he'd initially envisaged. And he was told he was to remain nil by mouth. Next slide, please, Lillian. So once they got home, there was Tom and Jenny together. This huge thing had happened to them. They were having some support coming in, but they didn't know very much about the feed because Jenny had been trained to do the feed by now in hospital. But Jenny wasn't an expert on doing feeds, and she felt that she didn't get enough information. She was totally overwhelmed by the expectation that had been put on her. And I've got the feeling from this, from listening to Jenny talking, listening to Tom and Jenny when we were at the meeting with them, and it really, really was very, very powerful listening to Jenny talk about that time when Tom first came home. Tom began to have a very low mood. He experienced real negative thoughts. He couldn't eat. He was just being fed via tube. He didn't feel that life was normal at all. He was very, very frustrated at not being able to eat and drink and have his own food. And what upset him even more was if he smelt cooking food, because that would make him salivate, he'd want to eat and drink. And although he was theoretically getting the calories and the nutrition he needed via the tube, it wasn't satisfying him in the other ways that food really satisfies us as human beings. And Jenny couldn't cook. She felt that she couldn't cook. She couldn't produce those delicious smells that had been such a wonderful part of their married life previously, where she'd cook them a delicious meal and they'd sit down and have a chat together. She stopped cooking. So Jenny stopped almost eating. She would eat in the kitchen on her own. She couldn't eat in front of Tom, and she wouldn't eat a cooked meal. She'd eat something cold so that it wouldn't have a negative effect on him. So Jenny lost weight. So rather than making one person better, we'd actually made two people arguably worse. And Tom felt worse because he saw Jenny deteriorating as well. Next slide, please, Lillian. So the carers who were coming in fortunately realised that there was a negative outcome for Jenny as well as Tom at this point. And Jenny was encouraged to contact the GP, which she did do. The GP came in and visited Tom, and they had a real good sit down, a real good discussion about what was important to them. And I think that's so important in safeguarding, because we can, as professionals, we can think that we know what's best, but actually until we ask the person, until we really explore their priorities, we don't know what's best for them. And I think that came out with some of the things that other people have come in and said on today about Bavinda saying that people had hidden fears. And I think for Jenny and for Tom, they didn't feel that they could speak up and say exactly what they wanted, because professionals were telling them really what they needed. And that can be quite intimidating for people when actually we're not the experts on them. We are the experts on what we can offer, but not on what they really require. So the GP did do a capacity assessment on Tom around his ability to make a decision, and he didn't have capacity to make a truly informed decision. So a best interest decision was made, and it was a plan that would suit both of them, and it was what the GP thought was in the best interest of Tom. So that Tom would eat small quantities of meals at Hingerwood. So Jenny could go back to cooking. She could go back to cooking a meal that they could have together. She would have the amount she wanted. Tom would have a smaller amount, and it would be in a consistency that was okay for him to tolerate. And Tom was given, and Jenny was given the advice that if Tom starts to cough, slow down. He doesn't have to eat all his dinner. He's having lots of nutrition via the tube. However, it suited them. Jenny could cook, Tom could get hungry, they could eat together. Made a true difference to their life together as a couple. Next slide, please, Lillian. So the lessons we've learned, I think when Rebecca said earlier that we have to hold a mirror up to our practice, I think this case really did that for me, because it really made me think about what is important to the individuals, not necessarily what professionals think, but what's truly important to the people. and you do have to try and understand things. We can't ever truly put ourselves in another person's position, but we have to give it our best shot. So what we've learned is that person-centered planning really means about person-centered. So what's important to the individual? And it may be that it is the very safest option to be nil by mouth, but is that right for the individual? And is that right for the life that they want to lead? Listening is very important. And as some of the commentators have said today, listening is not always easy because people don't always want to talk to you. And you have to elicit their feelings and their thoughts in different ways. You have to engage them in different ways. And it wasn't until the GP really came round and started to dig into what was the important things for this couple that we really got a better insight into it. Food is more than nutrition. I think I knew that, but when I heard Jenny say that how important it was about sitting down and eating a meal to Tom, it took on a whole new meaning for me. So I think for them, their meal times together was part of their life and a huge priority for them. And also about involvement in the plan of the individuals, not just an agreement. So Jenny did agree to manage the tube. However, really, she'd agreed it really wasn't on her plan of things she wanted to do and things that made her feel confident. In fact, it ebbed away at her confidence and didn't make her feel very good in herself at all. And also we need to give meaningful information to the person that actually is using the information and check that it does help them to do what we want to do. I mean, I've said PEG tube several times today. We say PEG when we're explaining to people what a percutaneous endoscopic gastroscopy is. It's a lot of words and it doesn't mean anything unless you're in the business of healthcare. Things take a lot of explaining because it's outside of a person's usual everyday world. And then again, check in on how people are going with the plan that's been put in place, because a plan always needs evaluating, always needs looking at, always needs, I would say, nearly always needs tweaking. So we've learned that we need to check up on people quite quickly. And of course, we know this, but we always have to remember that people are the experts on their own lives. We might be experts in little bits of the things that will help them with their lives, but they know what's right for them. Thank you. Are there any questions?
No, Liz, I can't see any questions at this stage. If anybody does have any, we will try and keep 5 minutes at the end. And Liz, you're staying for the end of the session, aren't you?
Yeah, yes, definitely. Yeah. Thank you.
Okay, brilliant. So I'm going to hand over now to Laura Busey, who is a social worker in the adult social care team at Coventry City Council. Laura, are you on the call?
Yes, I am.
Hello.
Hello. Yes. I'm going to talk about Arthur's story. Can I have next slide, please, Lillian? Yes. Arthur was a 74-year-old man. He had a stroke and was receiving physio support. He also was diagnosed with dementia. And he was married with his wife of 27 years. Next slide, please. During physio, Arthur disclosed that for 27 years of marriage, he was being physically, financially and emotionally abused by his wife. He lived with his wife in a one-bedroom bungalow, and his stepdaughter had moved back in with them and was sharing the bed with her mom whilst he was sleeping. He was made to sleep on a camp bed on the floor. Arthur was in the army in the past, and then he worked diverse jobs before retiring. He came from outside Coventry, so the wife was from Coventry, but he came from outside. Next slide, please. So after disclosing to the physio that he was being a victim of domestic abuse, case was referred to the local authority and allocated to me. On the very same day, I booked an appointment with the physio to do a joint visit. So I went like 15 minutes before the set time, and I was lucky to find Arthur sitting outside in front of his porch, and the source of concern, the wife, wasn't there. So I asked if I could go in, because the neighbor were looking, if I could go in the house and speak to him whilst we were waiting for the physio to come around. And we went in and he explained that he wasn't allowed to use the phone. I couldn't see him because his wife would not allow me to see him, but I needed to find a way of seeing him. Whilst I was there, the physio came and the wife came, and I realized that, yes, it was impossible to see him. So I needed to follow up later on. I called the house to speak to him, and the wife said I couldn't. Anything I wanted to say, I should say it to her. I said I couldn't, and she became abusive, and I made a referral to the police because I was concerned of the way she was talking to me. I thought I needed somebody to go and do a safety check. So the police went, and unfortunately the wife was there, and they asked Arthur if he was fine, and he said, yes, I'm okay, there's no issue. And the police then made a referral anyway to I'm forgetting. They made a referral to Age UK, to Jackie Sweet team, and she called me and asked what I wanted to happen, and I explained the situation, and she said, since the wife was an obstacle, was stopping everybody from seeing Arthur, there was nothing she could do. And left with Arthur, I couldn't. I decided I have to do something. So I went through the GP, and GP said he was also experiencing the same thing. Wife wasn't allowing him to see Arthur. Case was referred to Domestic Violence Agency. They also tried to make contact, but due to non-contact, because the wife would not allow, they closed the case. Then I decided to just work with the GP. Next slide, please. GP gave Arthur an appointment, but the wife turned up. Instead of taking Arthur, she went. I was to meet him there. The GP called me and said, please do not come because the wife has turned up instead of Arthur. So I couldn't attend. Then a couple of days after, Arthur felt unwell and visited the GP, and he was in a bad shape. So GP sent him to hospital and he was admitted. Then GP called me to say, he's in hospital, you could go and see him there. So I went to see him in hospital. I completed a positive risk assessment because Arthur was, I offered Arthur to move into a housing with care, but elsewhere in Coventry, he said to me that the wife will find him and hurt him. All he wanted is to move back to where he came from, go back to his family. With a nurse in hospital, we tried to find his family. He gave us his brother's name and first name, but unfortunately we found 18 people with the same name and first name, but different addresses. He couldn't remember his brother's address. He said if he gets into where they lived, he would recognize the house. So the nurse said due to his label of dementia, she would not support Arthur going to where his family were and looking for them because he may get lost. So I said, let us complete a positive risk assessment, which we did. He recognized all the risks, but he said, because if I move into a housing with care, she will find me and hurt me. I'm agreeing to go back home. It's better for her to have me there and hurt me than to her find me and hurt me. Either you send me to my family or you don't. And I'm going home. So we made him sign the risk assessment, which the nurse didn't agree because of a label of dementia. And I said to him, if I give you my phone number, would you be able to save it, keep it safe? Because he didn't have any contact detail of his family because the wife has destroyed all the details. He said yes, so he put it in his glasses case and he was discharged home. Next slide, please. Oh, sorry, I've missed. So he was discharged home and a family managed to call him, and the way the wife was speaking to him, they were really concerned, but he managed to say to them, I've got the social worker's number, and he managed to pass. I don't know how he did it. He managed to give my number to his family, and when I put my phone on a Monday, I saw that the family have called me on they called me on a Saturday. So I spoke to them on that Monday and said to them, okay, this is the situation. Are you willing to support? They said, yes, we can support. I said, okay, I will speak to the GP and see how we could support, because you can't go to his house to try and collect him. So what they did, and GP agreed to give an appointment. And then I called the family and said, GP has given the appointment for such a date, and if you could get here in Coventry and collect him from the GP surgery, which they agreed. So Arthur managed to go to the GP on that day. Wife let him go, so he went alone, and the family collected him. The family called me to say, we've got him, which was good. And they took him to the bank and cancelled all the card to stop the wife from taking all his money, because Arthur did say, which I forgot to say, that out of his wage for 27 years per month, the wife was giving him £10 and taking all his wages. So to stop that from carrying, the family took him to the bank and cancelled the bank cards, and then they left Coventry. On their way on the motorway, they called me to say, we've got him, we're going, we've sorted everything. And before that, I got in touch with domestic violence agencies where he was going, and he had a support worker waiting. I also got in touch with local authority there, so they were waiting for him. They had a place for him to go and live temporarily to facilitate the assessment. So Arthur went, and yeah, it's now a story. Very, very happy. He wanted to remain in touch, but I just said to him that I was just doing my job. So the lesson I learned here, it's the importance of working together to safeguard adults in our care, vulnerable adults. If this GP didn't work with me, I wouldn't have been able to listen or put in place what Arthur wanted. So that's the main lesson I learned in this case, that it is important to work with professionals like Professor Preston Schutte said, to work together with people, professional around the person. And that was really, really helpful. So that's the end. Please.
Okay, thank you, Laura. And I think Andrew's just put a comment in there, and it really sums it up to say thanks for a really great example, which demonstrates some of the best practice tips Michael talked about seeing the uniqueness of the situation, being curious, focusing on the relationship and being persistent. And then he's put, oh yes, and have no fear. And I think that case absolutely sums up all of those elements. So thank you.